First thing I want to say is that abdomen X-ray is quite limited value, so we don't see as many X-ray abdomens as what we used to do. Obviously, X-rays are the cheap option, you know, compared with ultrasound and MR and the like. But the problem is that they don't 100% exclude a lot of these pathologies that we're going to be talking about. So things like small bowel obstructions, ileus. The problem with small bowel is that it tends to be fluid filled. The only things that we can see on the X-rays are interfaces. So usually interface between air, which appears dark on the X-ray, and the soft tissue, which is grey. When something's fluid filled, that also appears grey. So in small bowel obstruction, unless it's air filled, we're not going to see it. So it is quite limited. Acute abdominal pain, we would X-ray for perforation as well, although we tend to do an erect chest X-ray because air rises, and when you do a erect chest X-ray, you're bilking for air below the right hemidiaphragm. But we do abdomens for that, and in cases of extreme perforation where you've got a lot of gas, that is quite easy to see on the abdomen. And you know, inflammatory bowel disease as well, colitis, X-ray can have some value, but again, it depends on the severity of the disease. And in the early stages, sometimes it isn't going to pick it up. So more often than not, if we see something suspicious, or if we, you know, if the X-ray is normal but there's still clinical concern, the patient will go on to have a CT of the abdomen. We have what's called I-refer guidance from the Royal College of Radiologists. They're really good. If you can get hold of them, it'll tell you what, you know, what guidelines indicate an abdominal X-ray and what don't. But it's used best for a preliminary evaluation rather than definitive. On the X-rays, I've said it's all about interfaces, so it's all about contrasts, and the main things we could see on the X-ray are gases, which are dark, masses, which tend to be lighter because they're denser. Less X-rays are passing through, so they appear brighter. The bones, obviously, and any stones on there as well. So renal stones and sometimes gallstones. Not all gallstones are visible, but some are. Things that you wouldn't do abdomen X-ray for, things like constipation, because that's more of a clinical diagnosis. You can occasionally do transit studies where they put a little radiopaque marker. The patient will swallow it, and you'll follow the marker around, and you'll do X-rays at intervals. We don't do many of those, to be honest, these days. Biliary pain, we don't tend to do it either, because again, only around 10% of gallstones are visible, and it won't show any other pathology of the gallbladder particularly. And it has limited value in things like pancreatitis, particularly acute pancreatitis. CT is indicated for that. Although in chronic pancreatitis, you can get calcifications of the pancreas, which will show an X-ray, but more often than not, you'd need some further imaging for that as well. This is a normal abdomen. We've got, obviously, you've got the bones, which you can evaluate, lumbar spine and pelvis. You've got bowel gas here, coming around here. So this is the large bowel or the colon, and this mottled appearance is normal fecal residue. Sometimes we'll describe it as excessive fecal loading. So that is when you've got this residue all the way around the colon and it's quite densely compacted. You'd obviously see that in patients with constipation, and there is a bit here of sort of moderate excessive loading, but not too much. And the key is you can see gas all the way down to the rectum, and the bowel isn't overly dilated, and we'll go into bowel obstructions in a bit. Just an incidental note, we've got some what we call sacralization of L5. So part of this fifth lumbar vertebra is fused with the sacrum, so you can pick up incidental bony malformations on there. You can see the outline of things like the liver. Because they're surrounded by fat, it makes them more visible. Occasionally you can see kidney outline. We've got the outline of the psoas muscle that runs down here either side. When we're talking about the abdomen in our reports, we'll split it into sections to make it easy to describe the location. And some people will refer to it in terms of hypochondriac and hypochondriac regions. I think that that causes quite a lot of confusion, and to me, I tend to describe it in terms of quadrants. So number 1 would be your right upper quadrant. Left upper quadrant, number 3, umbilical region at 5, right lumbar region, left lumbar region, right lower quadrant, left lower quadrant, and rectal area and epigastric region. And I think that creates less confusion among clinicians rather than saying hypochondrium, some of them, they'll phone up and say, we don't know what you mean. So as I've said, often you can see the outline of some of the main organs. So kidneys sit here. Left kidney is usually higher than the right kidney because the liver pushes it down. Should be roughly the same size. You can often see the outline of the liver and sometimes the spleen as well. And the straight psoas muscles coming down here as well. So we'll go on to bowel gas patterns and what pathology we can see. And the first one would be small bowel obstruction. It's the most common cause of mechanical bowel obstructions, accounting for about 80%. The main cause, particularly in adults, is adhesions from surgery. Occasionally it can be secondary to malignancy, but more often than not it'll be as a result of surgery or an incarcerated hernia. So if you had an umbilical hernia and some of that, or an inguinal hernia, and you can get actually sections of small bowel that get trapped within that. Sometimes it can twist on itself, or sometimes it'll just get cut off at the orifice site of the hernia, causing obstruction. But as I've said, X-rays are particularly sensitive, about 50% sensitive, because if the small bowel's fluid filled, you're not going to see it, and that's where you need to get your CT imaging in there if there's ongoing concern. In the textbooks, they'll say if it's over 3.5 centimeters in width, and you can see at least 3 or more small bowel loops of that diameter, then it is a big sign of small bowel obstruction. Personally, for me, you can visibly see when it's stretched. So you don't often see small bowel on X-ray. Normally, it is fluid filled. It looks visibly distended. I'll show you an example in a minute, but the bowel is inflated. You can see multiple what we'd call valvulae conniventes, or thin folds within the bowel wall. So we know it's not large bowel because the folds are slightly different, which I'll show you. And it's obviously dilated. So I don't tend to go off specific measurements too much. I tend to rely on, on experience and by eye to say, this is distended. But the textbooks will say over 3.5 centimeters. You can tell it's small bowel by those valvulae conniventes, those thin folds. It'll also have quite a tight radius of curvature. So the large bowel, you'll see a loop of bowel, but it will be quite a wide radius, whereas you'll see a lot of, in the small bowel, snaking type loops, and it will be more central in location more often than not. And we see on this example, this is quite an extreme example of small bowel obstruction, but you can see we've got multiple dilated small bowel segments over the 3.5 centimeters, and these are multiple lines, these folds in the bowel wall, these valvulae conniventes. So this is classic small bowel obstruction. These little coil things here are hernia repair mesh. So the patient has had a hernia in the past. This could be secondary to another hernia. It could be due to a tumour or malignancy that's blocked it off, or they may have had, recent surgery of the surgical clips here. They may have had this hernia surgery recently, and it's led to adhesions of the small bowel. Large bowel obstruction is rarer, but in experience we see quite a lot of that here. The most common causes in adults are going to be colon cancer and diverticulitis. Diverticulitis is where you get diverticular disease, so you get multiple pouches developing within the bowel wall, and over time those can become inflamed, and they can actually get inflamed and grow inwards, and it You get this sort of scarring, this fibrosis, and it blocks the bowel. The bowel gets quite inflamed. More often than not, though, it's secondary to malignancy. And you see any evidence of large or small bowel obstruction, they'll need a CT, and then you'll be able to evaluate it properly. Patients will present with sort of generalized abdominal pain. It'll be, visibly distended. Sometimes you can feel a palpable mass, and they'll have a failure to pass flatus or stool. On the X-ray, if the loop of colon's above 5.5 centimeters, then it's set to be dilated. The problem is, particularly in older patients, they have quite saggy colons normally. Again, though, often in cases of bowel obstruction, it's almost like they've been blown up with a balloon, so they're obviously dilated. They look stretched. The actual thick, what we call haustral folds of the bowel are no longer present because it's like a balloon that's been. If you have an inflated balloon, as you blow it up, it gets more and more stretched. Exactly the same with the bowel. And if we look on these examples here, this is a normal colon, this is transverse colon, and you see these thicker folds, these haustra. In this case of large bowel obstruction, you can see it's obviously quite wide, but we're losing those haustral folds as well because it's been blown up so much. Incidentally, this left total hip replacement, this is a ring pessary here. This is for rectal prolapse, to stop rectal prolapse. But then to confuse us, confuse the issue, we've got this thing called adynamic ileus. So this is where, for whatever reason, the bowel has gone into shock and it's stopped working properly. So that's not secondary to a mechanical obstruction. Usually that's secondary to some surgery or some adjacent pathology, and the bowel has said, oh, I don't like this, I'm going to shut down. And that can be for a day, couple of days, and that specific section of bowel will not work properly. It can be asymptomatic, but it can present with the same kind of symptoms of bowel obstruction. You know, patients that have distended abdomen, they may have a bit of nausea and vomiting, abdominal pain. Occasionally, that section of bowel will cause other sections of bowel to also stop working properly, and you get what's called a paralytic ileus, and that will look exactly the same as a bowel obstruction. And often on the patients will go to have a CT and they'll say, you know, appearances in keeping with obstruction, but there's no obvious transition point, and they'll get diagnosed as this paralytic ileus. We see here these multiple, I'll call them distended rather than dilated small bowel loops, but we've got more than 3. They're under 3.5 centimeters, but you shouldn't really see this many distended small bowel loops. And this is a section here of ileus where you've got some adjacent pathology somewhere, and this section of the small bowel has decided not to work properly. Hopefully, you know, there's still gas and fecal residue going down to the rectum, and hopefully this will resolve on its own within a day or so. One of the major pathologies that we see occasionally is something called volvulus, and the most common volvulus is in the region called the sigmoid colon. And a volvulus is basically where you get twisting of the bowel on its mesentery, and that twisting causes that section of bowel to be blocked off. It's not very common. It accounts for less than 5% of all bowel obstructions. The vast majority are the sigmoid though, and they do have quite a classic appearance, which will show. Symptoms similar to bowel obstruction, so, you know, sort of mainstream bowel obstruction. So you get the bloating, sometimes palpable mass, nausea, constipation. But it's got this classic coffee bean type appearance on X-ray, and that's where you've got 2 dilated bowel loops that have been twisted on each other. So you've got the outer walls of the bowel, but you've also got a central wall where the 2 inner walls of the bowel are pressed up against each other. It usually starts at the left lower quadrant and it goes up into the right upper quadrant in that direction. The bowel will lack the haustral folds because it's so dilated. The treatment is to shove a flatus tube in, and more often than not, that will do the trick. Occasionally they'll have to go on and have surgery, and they'll have multiple X-rays to show, you know, before the tube insertion, after the tube insertion, to see if it's recurring, and they'll keep an eye on things for a while. This is a classic example. So it starts down here. This is the point where the bowel is twisted, and we've got these two dilated bowel loops. Looks like the classic coffee bean appearance. So you've got the outer walls and you've got the inner two walls that are pressed up against each other. So you see that appearance, it's almost certainly going to be a sigmoid volvulus. Then we can have a volvulus of the cecal colon. Exactly the same principle, where it twists on its mesentery, but this is rare. You see it in less than 10% of all volvulae. I've seen one case in the 3 years I've been here. It doesn't happen often. Tends to happen in more younger patients. We don't know why, but essentially the cecum will twist, and it will, unlike the sigmoid volvulus that starts at the left lower quadrant and goes into the right upper quadrant, this will start from the left-hand side, left lower quadrant, and either go up into the left upper quadrant or the left lower quadrant. It will have large diameter, over 9 centimeters, but the haustral pattern, because of the way that the cecum is anatomically, it has quite thick pronounced folds, so often those folds will still be maintained, unlike the sigmoid that doesn't have many haustral folds, if at all. Two examples. So it's twisted here, and it's actually, this is a dilated cecum that has come upwards. You can see it's still got the folds here. And in this example, again, we've started here. The cecum is twisted. It's actually gone up and round here. Again, we know it's cecum because it's still got these folds preserved here. Again, the patient will go on to have CT imaging, and they'll be able to see what's going on. Incidentally, on this patient, these clips here, so they've had a cholecystectomy, gallbladder removed. If you ever see surgical clips up there, you know, 99 times out of 100, that's what it's going to be. Pneumoperitoneum, we see, I don't see that often, but air in the pelvic, in the peritoneal space. Can be caused by a lot of things like peptic ulcers, often bowel obstruction, where it's got to a point where it's actually burst because it's so dilated. Things like inflammatory bowel disease, where you get ulcerations of the bowel wall, can allow air to leak out. However, you can get it as a normal variant of surgery, because if you think about it, if you're opening the patient up, you're introducing air into there. So often you'll do an erect chest x-ray after surgery, and people see air below the right hemidiaphragm, and they'll say, oh, no, God, that perforated. And actually it's not at all. It's just air that's been introduced from the surgery, and that will get absorbed naturally over the course of a week or so. So as I've said, you do an erect chest x-ray with it, because that will help show small degree pneumoperitoneum. So a small amount of air will show below that right hemidiaphragm. But the abdomen, although it's not sensitive to small amounts of gas, you will see certain signs if there is a lot of free air. Something called Rigolus sign, where you get air on both sides of the bowel wall. So if we go back to this example here, we've got air within the bowel and it abruptly stops, and we see the inner bowel wall, but because we've got interface between soft tissue and bowel wall here, we're only seeing one side. In Rigolus sign, you're seeing both sides. I'll show you an example. If there's a lot of air, sometimes you see the falciform ligament of the liver in the right upper quadrant, and very occasionally in peds, when you have a massive amount of free air, you will see something called cupola sign, where the air actually travels underneath both hemidiaphragms. So all the way across the hemidiaphragm, you will see free air. Classic example of pneumoperitoneum. There is something called Chilaiditi sign, which is a normal variant appearance where you get distended bowel interspersed between liver and hemidiaphragm. The difference with Chilaiditi's sign is that you won't see this very well-defined outline of the liver because the bowel is overlying it rather than the free air sat on top of it. And you will often see the folds of the bowel wall. With pneumoperitoneum, you've got a clear interface between where the air is sat on top of the liver. So you have this classic dome appearance of the liver and this nice, well-defined crescent of air here. There is a little bit here on this left side, but you've got to be wary that there is stomach gas now normally under this left hemidiaphragm. Here's Wriggler's sign. And you see what I mean? You can see the outline of both sides of the bowel wall here. So you see this nice, well-defined edge that you wouldn't see normally because of the interface between the soft tissues of the abdomen and the bowel wall. Falciform ligament sign, so you'd be forgiven for thinking this was a fold in the bowel, but it's actually the falciform ligament of the liver coming up here. This is massive pneumoperitoneum. You only see this sign with large amounts of free air in the abdomen. And even rarer, we've got cupola sign, where you've got this large amount of free air. Sometimes you might hear it referred to as football abdomen because they'll have a big round lucency within the abdomen that's supposed to represent like a football. It's a big rounded area here. But essentially we've got free air below both hemidiaphragms sat underneath the central hemidiaphragm. That's cupola sign. And then we move on to inflammatory bowel disease. Crohn's disease, although you can see it, and in the old days used to do a lot of fluoroscopic studies with contrast and used to see it quite well. But the problem with Crohn's disease is that it starts at the ileocecal valve and often affects small bowel. And as I've said, small bowel you don't always see on X-ray. So it's not the best modality to evaluate Crohn's disease. Well, it has similar features to this ulcerative colitis, which is inflammatory bowel disease of the colon. So it starts at the anus and works back up the colon. And because the colon's usually air-filled, we can actually see the signs. Usually affects younger patients, but you can see it in all ages. Has a very, very low association with something called ankylosing spondylitis. You may have heard of that, where you get what's called like a classic bamboo sign of the spine, where you get loads of flowing osteophytes up the side of the spine. Patients often present with diarrhea and severe abdominal pain. Sometimes they'll have a fever associated as well. Typically on X-ray, we're looking for thickening of the bowel wall, this mural thickening. And as that progresses, you start getting ulcerations in the bowel wall. Sometimes air can actually, you can get perforation, but you can get air actually trapped within the bowel wall itself, something called pneumatosis or pneumatosis coli. What you're looking for there is little streaks of lucency in the bowel wall. And I've got an example somewhere. You might see the term thumbprinting used. So that's where you have defined areas of thickened bowel wall interspersed with normal bowel wall, and it's supposed to look like someone's put the thumb on the X-ray, and it's that kind of thumb-shaped opacity. Another feature, for reasons that none of us really quite understand, is that the distal, and this is only the descending part of the colon, often appears featureless. So you lose those haustral folds. It looks like a bit of a drain pipe type appearance, and there'll be a lack of fecal residue within that part of the colon. Some people call it a lead pipe appearance. If you see featureless descending colon without any fecal residue, always raise suspicion there could be some ulcerative colitis going on. Here's an example. So we've got this, generalized distension of the small and large bowel, but you notice here this descending colon doesn't look quite right. It all looks similar width. Eagle-eyed amongst you might see a bit of mural thickening, bowel wall thickening down here. There's a lack of fecal residue within it. So this is an example of the lead pipe colon in ulcerative colitis. Here's a example of the thumb printing that I was talking about. So haustral folds are quite thick, but not this thick. You know, it's like someone's pressed the thumb into it. You can see it here all the way around the corner. So this is quite an extreme example. Normally you'd only see it in one area of the bowel, but this is actually throughout the colon. So quite a good example there. Very occasionally you can see this ulceration, this pitting of the mucosa. Often, traditionally, you would see this more with contrast imaging, with fluoroscopy and barium enemas. But occasionally on X-ray, you can see defined areas of thickened bowel wall interspersed with the normal areas, and I dare say there'll be ulcerations to this bowel wall. I'm sure I've got an example of pneumatosis somewhere as well, which we'll get to. This, and if we're not careful with colitis, it can sometimes progress to something called toxic megacolon. It's a complication from both types of inflammatory bowel disease, colitis, Crohn's disease, and often with something called infectious colitis. And it is quite a severe complication. It's a, I wouldn't say it's an emergency, but it's something that you desperately need antibiotic treatment and regular follow-up with x-rays, because what happens is over time that the transverse colon will get gradually more and more and more dilated and more ulcerated, and eventually it will lead to perforation, potential sepsis and death. So it's really important that we identify megacolon and get them the right treatment early. It's typically transverse colon. It will get massively dilated, and you'll often see pitting or this pseudopolyps. Typically, this kind of mottled appearance here, what we're seeing in this example. Thumb printing might be present as well. As I've said, they will treat it with medication. They'll get occasionally decompression, surgery in extreme cases. But what we'll do is we'll do regular follow-up radiographs just to monitor it and make sure that it's not progressing. Doesn't need CT necessarily. We'll just follow it up with plain X-ray. So this is a case of someone with colitis. We've got the classic thumb print in here, the descending colon. But if we notice this section of transverse colon here is markedly dilated, well over 6 centimeters. We've got this pitting here, this bobbly type appearance, a bit more thumb printing down here. So this is megacolon, and if you leave it, it will get worse and worse until it eventually perforates. And then we move on to gas in the biliary tree, known as pneumobilia. Now, this can have lots of causes, some of which are benign, and as a result of surgeries and ERCPs, when they go and do scoping and they have a look at the biliary system, if you're inserting a stent. Any sort of surgical or interventional procedure where you're opening the sphincter of Oddi and looking up, you've potential to introduce air into the biliary tree. Patients can have incompetent sphincter of Oddi's associated with various pathologies. Very, very occasionally, it can be a result of something called a gallstone ileus. So this is where you would have a gallstone developing, and over time that stone actually buries its way through the wall into the colon. And because it's gone into the colon, air from the colon will then go back into the biliary tree. It is rare. You don't see it very often. The stone sometimes, occasionally though, if it's gone through, sometimes it'll just pass normally, but sometimes it gets stuck at the ileocecal valve, and that's why we call it gallstone ileus, because when it gets stuck at that ileocecal valve, it will create essentially a small bowel obstruction as a result. The key here is to differentiate between gas in the biliary tree and gas in the portal vein. Gas in the biliary tree is carries a much better prognosis than gas in the portal vein. Gas in the portal vein you'd normally see in really nasty things like infectious colitis, necrotizing enterocolitis. It carries a very, very poor prognosis. Gas in the biliary tree, it'll look like a tree appearance, but it'll be more central. It'll be more central, and the vessel's larger. Gas in the portal vein, which we'll see some examples, it'll still have that tree appearance, but it'll be more peripheral, and there'll be a lot more smaller branches. Often the patient will have a CT or an ultrasound to further evaluate and see what's going on, and to try and determine the cause. As I've said here, that shows it nice on CT imaging. So we've got gas within the biliary system, but notice that it's central and that these are quite large channels here coming off here. So that's gas in the biliary tree. Gas in the portal vein, as I've said, nasty. Gas is more peripheral. It's quite easy to differentiate the two as long as you know what you're looking for. Has lots of causes, mostly bad. Necrotizing enterocolitis is a common one in peds. It implies necrosis or tissue death in these conditions, which is why it carries such a poor prognosis. In adults, often associated with things like sepsis, occasionally bowel obstructions, and very, very rarely in patients with COPD. Very, very occasionally in those patients, because the lungs are having to work so hard, occasionally you can get air leaking out into the vascular system and it ends up in the portal vein. But these are like case report type rarity of cases. So if we remember that example of gas in the biliary tree, where it was more central and bigger, bigger channels. This one you can see here, but it's peripheral, and the channels are much smaller. So we've still got that tree appearance, but it's a lot more peripheral. So this is gas in the portal vein, and again, CT shows it really nice, doesn't it? You can see the gas going all the way through the system there. Could be some free air as well, maybe secondary to I would suggest probably some kind of nasty inflammatory bowel disease. So those are the pathologies associated with abnormal bowel gas patterns. Does anybody have any questions at all at this point? The way that this is set up on my screens, I can't see any chat, which is really annoying. So if someone's happy just to have a look and read out if there's any questions, then that'd be great. If not, then we'll go on to soft tissues and bones.
There's nothing in the chat at the moment, Nick.
Okay. Yeah, brilliant. Don't be shy, because I know it's a bit of a whistle-stop tour and there's a lot of information to take in. So, if there's anything that you think of, just, feel free to interrupt me. It's not a problem. I'd rather do that than get to the end. And then if you're anything like me, you'll forget what you was going to ask by the time it gets to the end. So, okay, so abnormal soft tissues and bones. So don't forget to look at the lung bases. So we've got the lung bases on most abdominal films, and sometimes patients that have pneumonias can present with abdominal pain. The pain can radiate, so that can often be a cause, and it's worth having a look at the lung bases to see if there's any white patchy areas of consolidation. A lot of abdominal pathology can also cause pleural effusions as well, so have a look for those. You see here with the temptations to focus on the bowel, but what we might miss is this this small pleural effusion, likely secondary to some abdominal pathology. You can faintly see the other organs, as I've said. I mean, textbooks will say liver should be this size, kidneys should be this size. In my experience, you deal with fine margins. Somebody measuring is someone in trouble, really, because they vary so much from person to person. When you get things like hepatomegaly, splenomegaly, they're not just enlarged, they're usually obviously enlarged, grossly enlarged, and I would be very wary about going down the route of hepatomegaly, and when it's a centimetre bigger than it should be, because everybody's different. Kidneys, they'll say about 14 centimetres in length. Guys normally have slightly bigger kidneys for whatever reason, I'm not sure. But again, X-ray not ideal modality to analyze these organs, but on X-ray, if they look abnormally big, you would then recommend ultrasound in the first instance, because you're not using X-ray, occasionally CT as well. Keep an eye out for aortic aneurysms. Sometimes it's easier to see these because sometimes you get calcifications in the wall of the aorta, so it just makes it stand out a bit more. And often the aorta is quite well defined because the blood makes it a little bit denser. If it's over 3 centimeters, they'll need an ultrasound to properly evaluate. And if it's really bad, they'll need to go on for have what's called EVAR stent procedure to stop it rupturing. This is a case of hepatomegaly, so normally the liver should come down to around here, but if we see here, it continues down, and it actually comes across here. It's not very easy to see on X-ray, I appreciate, but you just have to trust me that it comes out here. It's actually lobulated, so you've got one bit here, and then it's actually like this kind of shape. But again, as I've said, everybody's different, and a normal variant is something called a rhidal lobe of the liver, and it's this tongue-like projection of the liver that comes down quite far down, and you'd see that quite easily on CT. If there's any doubt, if you saw this and you thought, oh, they've got signs of some kind of liver disease, or let's get a CT done or an ultrasound, and you'd be able to see what's going on. But this is a normal variant called a rhidal lobe. It's not technically a lobe, but that's what they call it. Enlarged kidneys, very difficult to see. This one almost completely obscured because you've got gas overlying it. This one, if very eagle-eyed amongst you, you'll see a faint outline up here. This is the top of the kidney. It comes down, 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 down. It comes right down here. So this is massive. You can see this in something called polycystic kidneys. You can get it in medullary sponge kidney, all manner of conditions. So again, the patient will need ultrasound, CT to further evaluate. I've just drawn the outline just to make it easy to see, because they aren't often easy. Aortic aneurysms. You can see that this one's got calcification. It's quite easy to see. We're seeing the, one side of it. We're not seeing the other wall, but it shouldn't bulge outwards like this. So get them ultrasound and see what's going on. This one more difficult, but if you look, we've got this faint mass-like thing coming round here. So this is a massive aneurysm. Again, this patient's going to have some kind of stent procedure or something, because that's got to be at the verge of rupturing, you would think. Similar with lumbar spine x-rays, remember to look on there. I've seen a few cases of lumbar spine reports where rightly focused on the bones, the spine, but they forget to look for things like aneurysms. And sometimes patients will present with back or groin pain, and they'll think, oh, it's going to be SI joints or lumbar spine, and actually it turns out to be an aneurysm. And I had an unfortunate case of one where the reporter had missed it and the patient had died as a result because they'd not picked up on the aneurysm. So always keep an eye out, because they will catch people out. You can get all sorts of masses in the abdomen. A lot of them are usually arising from the pelvis, things like ovarian tumours. You can get benign tumours called dermoid tumours or dermoid cysts. Teratomas, where you get the tumours interesting ones where you get tumours of different cellular structures within a tumour, and they can actually grow to things like teeth, hair, even eyes, in like confined to one tumour. It's quite interesting. Very occasionally as well, surprisingly, patients can have really distended, dilated bladders. So before they have the catheters put in, sometimes you'll see this big mass arising from the pelvis and you'll be like, oh my God, what is that? And actually, it's a distended bladder. This is a ovarian mass here. It's quite lobulated. It's regular and smooth for the most part, but it's not all the same oval shape. This is a continuous egg shape all the way around. So this is a tumor here, ovarian tumor. This is just a distended bladder, and that's how big they can get. They can be quite, you know, surprisingly large. I mean, the key here is shove a catheter in, see if it goes, you know, and if it doesn't go over time, then you've got to suspect that there's there's something else more sinister at play. But you notice it's actually displaced the bowel as well. So sometimes, even though it's a soft tissue structure, it's not much denser than the surrounding abdominal tissue. But a clue is that sometimes, you know, it will displace the bowel. So in both these cases, the bowel, you'll notice there's no gas here because the bowel has been displaced by the tumour, and exactly the same with the distended bladder. There's a bit in the rectum, but the rest of it has been pushed out the way. With a lot of pathologies, you can get fluid in the peritoneal space called ascites. It can be transudate, low protein, or exudate, high protein. That has a bearing, obviously, on what it is. So you can get it secondary to edema, which should be low protein, or infection, which should be high protein. The problem is, you know, that again, it's similar density to the organs and soft tissues in the abdomen. But what you find is, whereas you'd normally just faintly see the outline of the organs, what you'll actually see is just a generalized grey appearance of the abdomen, and you won't see those organs because it's a similar density. We're losing that interface between the fat surrounding the organs and the other soft tissues, because it's all the same density. It can push the bowel medially in extreme cases where there's a lot of fluid. If there's not a lot of fluid, it won't do that. Here's an example. So we're not seeing liver, we're not seeing kidneys, we're not seeing spleen. We're just seeing this generalized haziness throughout the abdomen. These are the lateral fat planes which have been pushed outwards by the fluid. So this is gross ascites within the abdomen. Don't forget to look at the bones as well. You can pick up all kinds of bony pathology, most of which incidental. Things like Paget's disease, degenerative changes. You could look at them and say, oh yeah, it's Paget's disease, but it's not really got much of a bearing on the patient. But occasionally you can see more sinister pathology like metastases, isolated bony lesions. Refer for dedicated x-rays if required. So if you see something sinister looking on the lumbar spine area, let's do some proper lumbar spine x-rays with a lateral to be able to analyse it properly. Okay, so this on the right hand side is Paget's disease. So on this hemipelvis is normal. So you've got normal trabeculates, normal sort of bony density. But on this side, you'll notice it's quite sclerotic. The cortex here is nice and thin. The cortex on this side is thickened. Paget's disease tends to be confined to one hemipelvis. You usually see it in the pelvis, but you can see it in the skull and other areas, but tends to be in one hemipelvis, and it'll stop abruptly at the edge. This, you've got this bobbly, sclerotic or white, patches of white. It's diffuse. You can see it going into the lumbar spine as well. We've actually got what's called an ivory vertebra, so it's complete white out of this vertebra. So this is metastatic disease. Typically, you'd see this in things like breast cancer. In the guys, you'd see it in prostate cancer. Diffuse sclerotic metastases throughout the bones. It's not like Paget's where it would just be confined to a bone. It would be, diffuse, systemic. Calcifications. 90% of renal calculi are visible on X-ray. So X-ray is quite handy, providing that the stone is big enough. They can be really small. or they can be massive. They can take up entire calyces, and it can create something called a staghorn calculus. So that's where all the calyces of that particular kidney have been filled, and it looks like, it's supposed to look like a stag's antlers, where the stone is actually mimicking the shape of the calyces. You can sometimes see stones that have passed into the ureter. Something occasionally after they've had certain procedures. So sometimes you know, if the stone is such in the kidney and it needs removing, if it's trapped in the ureter, they'll actually go up with a laser, and they'll fire the laser at the stone in the ureter, and then they'll put a little cage or a little grabber up to actually take pieces of stone out. Sometimes one of the stone fragments may actually get lodged elsewhere, so we've got Steinstrass. And again, you know, occasionally you can see that on X-ray, sometimes you can't. There's something called extracorporeal shockwave lithotripsy. That's another method of breaking stones up, usually within the kidney rather than in the ureter, and they'll use shockwaves to do that. Very occasionally you can get calcifications within the kidney tissue or parenchyma itself, something called nephrocalcinosis. You can see that in, again, all manner of conditions, including something called medullary sponge kidney. Bring some examples. So here, again, we're not seeing kidneys very clear, but we've got these stones here in the region of the ureter. So these are quite large stones, so they'll need to go in with laser treatment and remove those. We've got an example of the staghorn calculus here, taking up the calyces, and medullary sponge kidney. Gallstones you can't see that often. 20% of gallstones are visible on X-ray. We do see quite a few gallstones, but a lot of the patients with gallstones, you won't see them. It depends what material it's made out of, and that's why X-rays aren't particularly great. So if someone presents with sort of gall pain, you know, ultrasound is the better modality. Often you'll pick them up incidentally. You know, patient will be asymptomatic, but as I've said, it can occasionally be pathological. So if the stone erodes into the bowel and causes that gallstone ileus, they can lead to pathology. In cases of appendicitis, very, very difficult to see appendicitis on X-ray. You know, more often than not, they're going to need ultrasound CT. But one of the things to look out for is something called an appendicolith. And an appendicolith is like a little stone in the region of the appendix. Patients with those have a stronger association with appendicitis. So although they may not be full-blown appendicitis, those with an appendicolith, you would do some further investigation or keep an eye on them, because there is a higher risk. Here we've got these weird calcifications. So these are actually calcifications of the lymph nodes of the peritoneum. But here we've got these very faint multiple calcific densities in the region of the gallbladder. So these are gallstones up here. And this is an example of an appendicolith here, just a tiny little stone in that right lower quadrant in that appendix region. So the chances are this patient's got a strong chance of having appendicitis or progress to appendicitis. You can see lots of other calcifications. You know, you get a lot of vascular calcifications, particularly splenic artery and iliac arteries and aorta. In conditions such as chronic pancreatitis, you can get calcifications of the pancreas, and they'll actually follow the shape of the pancreas. So it'd be quite obvious that that's what it is. Very occasionally, you can get calcifications of the gallbladder wall. And at surgery, when it's removed, it's got this blue sort of whitey appearance called, you think like the old porcelain where you get the blue and white sort of Chinese style porcelain. It's called a porcelain gallbladder for that reason. It's got a high risk of progressing to adenocarcinoma. So patients with this condition, although it's found incidentally, sometimes often they'll have that removed. You'll get calcifications within the pelvis. Sometimes there might be little vascular stones called phleboliths. Sometimes there might be calcified fibroids, and sometimes they can be quite large. Here we can see multiple calcifications, and it's in the shape of the pancreas. You see it starts at the head of the pancreas and then it goes off to the tail. So this patient's got chronic pancreatitis. This is a calcified fibroid, so quite impressive, quite big, well defined, quite smooth in shape. Okay. So that's the pathology. Foreign bodies I don't want to concentrate on too much because it's either there or it isn't really. And most foreign bodies are pretty obvious, particularly if they're of metallic density, or even, you know, large plasticky density, because of the fact that it's all soft tissue that you're dealing with. You'll more often than not, you'll be able to see those quite easily. But if we look at some scenarios, now I just want to kind of open it to the floor and see what you think on some of these. So if you were seeing this, you know, this patient and looking at this x-ray and you saw this appearance here, what do you think that this might be? Have a think about it. Either I say, I'm sorry, normally I'd ask to put in the chat, but if you don't mind, if people don't mind speaking up, see which option you think. It doesn't matter if you get it wrong. I just want to see what people think.
Pneumoperitoneum.
Pneumoperitonemia. Anyone else? Are we all in agreement, or does anyone out think anything else? Okay, so it's actually this. It's actually chyliditis, and I've put it in just to show it can be difficult. But if you remember, this is normal stomach gas, but you remember me saying that in pneumoperitoneum, the free air sits on top of the liver. So you've got that nice clear interface between the dome of the liver and hemidiaphragm. You've got that nice clear crescent of air. Here, we're not seeing the outline of that liver clearly. And if you'll notice, we've got this fold here coming up here. So that's a fold in the bowel wall. So this is bowel interspersed between liver and hemidiaphragm. So just be careful not to get caught out, because it does trip a lot of people up. If you're unsure, you know, just ask us, or you know, very occasionally they'll do further imaging. But yeah, if you don't see clearly the outline of that liver, the chances are that it's going to be chyliditis sign, even if you don't see a fold necessarily in the bowel wall. Okay, this is a 39-year-old male that came in with severe abdominal pain. What do you think this might be? Now, this is quite difficult, and I can see, you know, why people would think a certain thing. But have a think about it and just see what you think. What do you reckon? So those stand for large bowel obstruction, necrotizing enterocolitis, pneumoperitoneum, Crohn's disease, small bowel obstruction, ulcerative colitis, or toxic megacolon. So have a think what we've talked about and see if you can pick out some of the key features and distinguish what it is.
Is that like what you refer to as a drain pipe feature there, Nick?
Yeah, perfect. So absolutely. So it's tempting to think this is large bowel obstruction because and to be fair, these are dilated. But we've got this classic lead pipe colon, haven't we, where it's completely straight. The folds of the bowel have gone. There's no fecal residue within it. This transverse colon looks a bit dilated to me. We've got what appears to be thickening of the wall. So I would suggest that this is ulcerative colitis, but I would be concerned that we've got some toxic megacolon starting to develop there. Maybe some little, there's some blotchiness here, maybe some pitting of the wall, some mucosal ulceration. So this is a classic case of colitis with that lead pipe appearance, as you said. Yep, so that's great. As I say, I suspect there's toxic megacolon developing there as well. Okay, so this one, this person had non-Hodgkin's lymphoma, which is progressing, abdominal pain and vomiting. What do we think? Do we think they've got aortic aneurysm, small bowel obstruction, hepatomegaly, splenomegaly, ulcerative colitis, large bowel obstruction or perforation? Anything that looks abnormal on there at all?
This is just a real random guess, but can you see an aneurysm there? Like,
yeah, I can see.
Is that...
I can see why you'd think that, because we've got this. Do you mean here?
Yeah, is that something completely different?
No, you're right. We've got this density here. We've got outline of one kidney here. So I think that this is a kidney coming round here, but this doesn't look quite right, does it? This spleen looks a bit big. It looks a bit dense. It should come down to about here, and it's actually coming down to sort of iliac crest. So this is splenomegaly, and it fits with the history because often with the spleen, you know, it's associated with lymphatics, non-Hodgkin's lymphoma. Often, you know, patients can present with enlarged spleens. So that's a case of splenomegaly, quite subtle, but it just looks a bit dense as well. It looks a bit bulky. It looks a bit too big. Again, you know, it's one of them things that if you missed it, you know, these patients will have further imaging. It's not the end of the world. It will be picked up, but occasionally you might be the first person to see it on an X-ray. This patient's coming with abdominal pain, the querying obstruction. Is there anything on there that's abnormal? If so, what do you think it is out of those options? Might not be, you know, might not be anything sinister. These are the phleboliths I was talking about. They're very smooth, well-rounded. The vascular stones, and one of the key features with phleboliths is if you zoomed in on them, that they'd have like a little lucent center to them. But you see this? This density is a bit odd because it doesn't look like a typical fibroid. It's not really big enough. It doesn't look anything sinister particularly. So we did some further imaging and it turned out to be a dermoid cyst. And often these patients, you know, they'll present with these calcifications and actually, you know, they'll end up being like tooth formation within the tumor and things like that. So this is a benign tumor, or it was called a dermoid cyst. The outer aspect of it you probably struggle to see, but this is the calcified component within. Anyone hazard a guess as to what's going on here?
I was going to say small bowel obstruction, but then you can see bowel all the way down to the rectum, so I don't know if that's right.
Yeah, I would say you're absolutely right. Yeah, I mean, you can see a bit, can't you? You can see these thick folds, so there is gas beyond it, but that's not to say, you know, it might be an incomplete obstruction. It might not be a complete mechanical obstruction, but the presence of these, you know, we've got these valvulae convergentes, these multiple folds, so we know this is small bowel, and to see that much dilated small bowel is not normal. You would not see that normally. So there's got to be a reason for that, and almost certainly it's going to be some kind of small bowel obstruction, or maybe a paralytic ileus. if they've had some really recent surgery or something. But this is small bowel obstruction. It can be hard to separate the wood from the tree sometimes. So it's, you know, is it small bowel? Is it large bowel? It helps when you can see these folds, because you know it's small bowel, and it'll have a tighter radius of curvature. Patients come in, abdominal pain. What do we think this might be?
Either a distended bladder or a mass, ovarian mass, perhaps, because there's definitely some kind of irregularity at the bottom that could be some sort of calcification or something. But then there's obviously this hugely either distended bladder or abdominal mass, I would say. Yeah,
so distended bladder, I would say. I mean, if it was the only X-ray, it could be either, couldn't it? This, I think, is a tiny tip of a urinary catheter that's been shoved in. So you would you could do another X-ray and see if it's gone down after that catheter's worked its magic. It's quite egg-shaped. It's quite uniform, which would make me think, it's probably not something sinister, but that doesn't mean to say it's not. So yeah, if it's a first X-ray and there's concern, do repeat X-ray after the catheter's in. If it's still there, let's do some further imaging, like a CT or ultrasound, just to make sure. But yeah, this one is a distended bladder.
Can I just ask then, if what you think you can see at the bottom is the tip of a catheter, why is the bladder still distended? Is it like incorrectly placed, or?
If you look, it's only just in it. So whether it's not quite, in the right place, or whether it's only just been inserted, I'm not sure. I guess what you'd just say is, if I was reporting it, I would say this is likely to be a distended bladder, but please review the catheter position, correlate clinically. If there is any concern, let's do further imaging, because it's so. X-ray is very non-specific, isn't it? We know there's a mass there. We can't be certain. It looks like distended bladder, but as you say, if there's a catheter there, we don't know if that's working or not. That's the problem. We're kind of reliant on the clinical information provided, and it's often very vague. Whereas they've got them in front of them, they can see if it's working or not. Adjust the catheter. If they get a lot of wee out and it's still like that, then we'll do some further imaging and take it from there.
Thank you.
Okay, so that's it. I mean, I've put a few resources up here. These are good websites for classic imaging examples. Information is okay, more so on Radiopedia, but they're very good for your classic X-ray examples. So do go on there and have a look. There are some books. This one's a very good book to go over the basics, and it's quite cheap to get hold of. We might have a copy here if anyone needs it, called Abdominal X-rays Made Easier, and it goes over all the basic pathologies and the X-ray appearances. These are a bit more, sort of foot thick textbooks, which they are good for information, but they can be a bit overwhelming. This is more like a pocket book, and it's a good resource. Okay, so I appreciate that's been a bit of a whirlwind tour of it, but has anybody got any questions at this point at all? I'll take this off, stop sharing, if I can, if it'll let me. No, is everyone happy? If you do have questions, don't like I say, you've got my links there on social media, or just email me nicholas.barlow@nhs.net, and I can go through some specific examples or answer any questions. It's not a problem. I hope it's been useful. I've tried to include as many classic examples as I can. It's not always as black and white as that, and there are a lot of dodgy examples, but you know, on the whole, though, you know, if you see those signs, you won't go far wrong in your interpretation. So I hope it's been useful.
Thanks, Nick. It's been really great. Thanks for your
All
time.
right. So my colleague Rob, I think, will do the next talk, and he's going to do some stuff on the chest, I believe. So, and he's very good. You know, he's got a lot of experience, same as me, at reporting, and he's good at teaching. So I hope you'll enjoy that one as well. But thanks for the opportunity for me to come, and I hope it's been useful.
Thanks ever so much, and thank you everybody for attending. It's been wonderful. Thank you.
Take care, everyone.
Take care.
All right.
Bye-bye.
Thank you.
Thank you very much.
Bye.
Thank you.
Yeah.
Thank you.